Leia Healthcare, looking after you always. Proud sponsors of Real Health with Carl Henry.
Hello and welcome to Real Health with me, Carl Henry, in association with Leia Healthcare. Folks, on this week's Real Health, I won't lie, I am absolutely very excited. This is going to be epic. We're going to be talking about weight loss surgery. It's a topic we have touched on before on the podcast, but this week we're taking a deeper dive and bringing you absolutely everything you need to know about the procedure. There's now a general acceptance that the eat less, move more approach to dealing with complex obesity really isn't suitable, which means treatments like bariatric surgery are getting more attention. But what exactly is involved, and what do people need to know before they undergo the procedure? Joining me to discuss this is consultant bariatric surgeon at St. Vincent's University Hospital, Helen Heneghan. Helen, I am really excited. Welcome to the show.
Thank you, Carl. I'm delighted to be here and that you're addressing this really interesting, I think, an important topic.
Oh, it's a fascinating topic, and it's a topic that is becoming more applicable to people all across the country as the population grows and grows and grows. First of all, let's just set it out. What is it? People will hear the term all the time, so let's start there in terms of what exactly it is.
Yeah, it's really important to define it because there are a lot of myths about bariatric surgery, and I might start with saying what it isn't.
Yeah,
so
great.
It isn't cosmetic surgery, and it isn't just gastric banding. So I often get referrals for patients for gastric banding, or it's not a tummy tuck. It's none of those things. It's surgery on the gut that helps people to lose weight, but more importantly, it increases people's health and function and quality of life. So it might be better termed, health gain surgery. We often call it metabolic surgery as well, because that better defines what it does. The weight loss that is quite significant from it is almost a secondary benefit. It's all of the health improvements, and there are many weight independent mechanisms by which it works. So there's many other benefits than weight loss that we see even before, within hours or days of surgery, such as remission of type 2 diabetes, improvement in blood pressure, cholesterol. They happen hours after these operations. So essentially, back to what it is specifically, it's operations where we change either the shape or the route of the gastrointestinal tract. So the commonest operations, and most of them are done by laparoscopic or keyhole surgery, almost exclusively now. So it's minimally invasive surgery, and the most common procedures at the moment and the most effective ones would be gastric bypass surgery and sleeve gastrectomy. So we no longer perform gastric banding as a routine operation. It was very popular about 20, 30 years ago, probably for the wrong reasons. Carl, it can be effective in a very small number of patients, but it was the safest operation on the day of surgery 2-3 decades ago. And
which was a band around the stomach.
Yeah, a silicone band that's adjustable, a bit like a tyre, I suppose. You could put water or saline fluid into it and take it out of it through a little port that's hidden under the skin, so to make it tighter or looser as needed. And the idea behind it was that it helped people. It was placed really high in the stomach, so it created a gastric pouch or a small stomach, so people felt full really quickly. And it does, it's an effective operation. It's very safe, but it's the operation that carries probably the longest, the highest long-term risk. So only if you look, the most recent data would indicate that of all people who've gastric bands, about 2/3 of people need them removed within 8 years, usually because of complications like the band moving slightly. The stomach is a very mobile organ. As we breathe, our stomach is moving up and down. So having a fixed band around it is not ideal. So the stomach moves within it, and sometimes that can force the band to lie ever so slightly differently, which can cause reflux, heartburn, difficulty swallowing solid foods and arguably healthy foods, and people can maladjust to that and actually gain weight with them in that instance, and it causes significant trouble with the motility of the esophagus, which is damaging in the long term, and for majority of people they just don't work because people find ways around them. Essentially gastric banding doesn't change gut hormone production, doesn't really change the microbiome, so it doesn't have a lot of the benefits of other bariatric surgeries like the bypass and like the sleeve.
So that's the old school one.
Yeah.
So
just make it feel
not really
full.
done anymore. Gastric band around the tummy. Generally,
Yeah.
after eight years or so, you're getting adjusted or taken out or whatever. And okay.
Or have had no benefit.
Okay. And then sleeve is the next one?
So the sleeve gastrectomy has really become probably the most popular operation internationally over the last 15 years. It's a simpler and slightly safer operation than the gastric bypass and involves removing about 3/4 of the stomach. So it focuses only on the stomach, and there's no change to all of the small bowel that would be involved with a bypass. So it carries slightly less risk, but for that reason, slightly less benefit as well. So the weight loss is very similar to the gastric bypass in the short term. So for the first 2 to 3 years, weight loss from a sleeve gastrectomy is about 25 to 30% of one's pre-op weight. Wow. So quite significant, but there's a higher chance of regaining weight than with a gastric bypass. So as we know obesity is a disease, and I can talk about that later on, and that's really important to I suppose having good treatment programs in place for it. Acknowledging it's a disease is important, but it's a chronic disease that's you can't really cure, and it's taken me a long time to accept that. I think when I started out doing this, I thought, because of the great results that we see, I probably hadn't been doing it long enough to see weight regain, so I thought everybody was cured of obesity, and that's not true. People live with obesity lifelong, and like any chronic disease, you can treat it, keep it in remission, I guess, but there's always a risk of weight regain, and that is slightly higher with the sleeve gastrectomy within the gastric bypass.
And what causes the weight regain with the sleeve then? Why is that the one that people tend to put weight back on with?
Because the stomach, a lot of people think, has my small stomach. And just for context, we change the shape of the stomach from what would be quite typically the size of a rugby ball in all of us right now. It's about that length, our stomach, and about that diameter if it was stretched out. And we change it to the shape and size of banana. So it goes down to being about 2.5 centimeters wide, which is well enough to fit a nutrient-rich small meal. And it's well enough stomach to survive on and feel, eat enough and be really healthy with. But it rarely stretches out, and we do investigate people for that and see, could you, reduce the size even more? But it's, again, multifactorial. It's the same reasons that often led to weight gain in the first instance. It's being genetically predisposed to it, and then, I suppose, in an environment which is obesogenic and helps people put on weight really easily. So people there's a honeymoon period with these surgeries where there's about 2 years where people are, less hungry, feel really full, and that can wane over time. So we, often can change sleeve gastrectomy to a gastric bypass or to another surgery where you add in a component of malabsorption. So reroute the small bowel, change it essentially to a gastric bypass, or a more malabsorptive operation. But the risk that comes with that is higher than with the first operation. So now, with the great advances in medication for obesity, we add them in afterwards if someone experiences weight regain, and they can be quite powerful in addressing that again. So we've lots of options, but the sleeve, I suppose, it was first introduced as a stepping stone to a gastric bypass, where people had too high a BMI or too great abdominal obesity to have a gastric bypass safely at the first operation. So it was considered the right approach was a 2-stage approach. So do a sleeve gastrectomy, wait a year, get good weight loss, and then change it to a gastric bypass.
And chat us through the bypass then.
Yeah, so the bypass involves, I suppose, 2 steps. So the first step is making the stomach smaller, so separating a piece of the stomach we now have from what we would eventually call the gastric remnant, the part that's left out of circuit. And then the second step is rearranging the small bowel. So food essentially then takes a shortcut through the gut, and it doesn't pass through the majority, about 80% of the stomach, and the first half a metre of small bowel, that's completely rested indefinitely. So, it's the best example of intermittent fasting, I suppose. We know all the benefits of that. We know, and we've realised that a lot of the benefits of that through understanding how gastric bypass surgery works so well. If you rest an entire segment of gut for prolonged periods of time, you get great changes in gut hormones, in the gut microbiome, in bile acid production and absorption, and they have great benefits for health and for weight. So gastric bypass, you leave a good segment of the bowel rested indefinitely, and you've well enough bowel to absorb nutrients and macro and micronutrients left in circuit, but it's that bowel rest and excluding a part of the small bowel and the stomach from absorption of nutrients and from food hitting the mucosa of that bowel that's really significant in terms of understanding how the operation works. So you do have restriction as well in terms of having a stomach pouch that's about the size of, I suppose, a small fist or an egg. So you have a small capacity, but you also have hormone changes in the gut that lead to complete lack of hunger. Complete changes in your food preferences. So there's good evidence from our own unit that demonstrates that people who are put in buffet environments pre and post surgery, not being aware that they're being observed, their food choices completely change to being more protein rich, and that's I suppose it's unintentional in a way. It's just involuntary, I suppose is the better word. So they prefer healthier food choices after surgery, and that's all chemically driven.
Fascinating. Take a breath. You've been absolutely streaming content. I'm like a sponge trying to take all this content in. It's fascinating. Okay, so they're the 3 different types. That's really beneficial for people straight away to know the difference between them. Chat to me around the demand then on a national level.
So, there's huge demand for it. If you demand it, depends on, I suppose, who's eligible and who wants it. So I suppose in terms of people eligible for surgery, we don't even have a good idea of that. The best data that indicates demand at the moment comes from Roseanne Kenny's TILDA study.
Oh yeah. We had Roseanne on a few weeks ago.
And that, but bear in mind, that only includes adults over the age of 50, but it had very good weight data and BMI data in it, and data on their health conditions as well. So if you were to look at eligibility criteria for bariatric surgery, and they're driven by when it's safe. So when do the benefits outweigh the risks? And that happens generally when BMI is over 35 and there's a health related problem, like diabetes, hypertension, cardiac disease, sleep apnea. There's, as Donald would have said before, 200 conditions now linked to obesity. But you're eligible with any of those conditions and a BMI over 35, or even if BMI is 40 and you've no health condition at that time, the benefits of surgery would outweigh the risks. So knowing that means that if you apply those criteria to the TILDA data set, there are
huge population cohort.
So right now there'd be 100,000, and so even if you were to be really strict and ration surgery to only people with type 2 diabetes, because arguably they probably are the most cost effective group of people to treat, because medications for diabetes are quite expensive. So with diabetes alone, you've 93,000 people, in that one recent enough epidemiological study that used the TILDA data set to ask exactly this question. And if you were to be even stricter and we said, look, we only have money to do, the sickest people who will get the most benefit, and we took people with type 2 diabetes, BMI over 35, and a complication of diabetes, so kidney disease, eye disease, heart disease, there's about there's 92, there's 13,000 of those people straight away today, but that's only adults over the age of 50, and most bariatric populations have an average age of about 47, 48. If you look at all bariatric literature around the world, the average age of patients who undergo it is younger than that. So I think we're underestimating it hugely, because we just don't have good weight data on the Irish population. They're done through surveys, obviously every 4 to 5 years, and it's usually self-reported data, but we need to have a better idea of that. We know there's about 1 million people who have BMI over 30 in Ireland, so probably 80% of people with BMI over 30 are going to be vulnerable to or have a health complication related to their weight. So that's where obesity becomes severe and complex, and they're the people who would benefit from bariatric surgery. So I would estimate it's in tens of thousands, if not hundreds of thousands of people who will be eligible. Whether they want it or not, or it's the right treatment for them, is more complex.
And can I, on a national level then, what's our capacity for surgery?
Oh, we do the worst, sadly, in the Western world in terms of our provision of surgery for those who are eligible. So we currently provide it for less than 0.1% of people who are eligible. So there's only one functioning public service at the moment. That's our service in Vincent's and Loughlinstown. And we're doing about 100 a year, and the only surgeon that was
100 a year.
Yeah.
With a waiting list of a couple of hundreds.
Yeah, well,
not a waiting list.
Potentially,
yeah.
And there is a service that's almost that's not fully funded in Galway, but that will change.
That's right.
We have had good news in the last week, I guess, that the HSE.
There's one in Cork coming, I think, is there?
Yeah, the HSE have finally confirmed that there will be funding dedicated to bariatric surgery to allow the service to expand nationally. And absolutely, that'll allow us in Vincent's to increase our numbers. It'll allow Galway the unit in Galway to start, churning through their waiting list, which is about 700 people, and that hasn't even addressed people waiting to get into the service, and then to initiate a service in Cork. So it'll become more accessible in a timely fashion to people around the country. But we have a waiting list of about 4.5 years to get a first appointment in our clinic at the moment, because there's at last check a few weeks ago there was almost 3,000 people waiting to be seen in the clinic. So it's a really small team of people that deliver this care, and it is complex, so people deserve the time, multidisciplinary approach to do it safely.
Folks, you're listening to Real Health with me, Carl Henry, in association with Leia Healthcare. We're chatting all things obesity and surgery. It's absolutely fascinating and mind-blowing. It's wow. And it is important for those listening in. Helen has no notes with her whatsoever. This is all just straight off the cuff in terms of content, which is wonderful as an interviewer, but to get someone that expert who knows their topic as well as you do. It's important to say that and it's a good thing, I think, that the how we treat obesity has changed, or the view on obesity that we have. You're not obese now, you have obesity, it's a condition. And that move more eat less approach for those over a certain BMI or a certain weight range, it's not particularly applicable for them, because the benefits from it, moving you'll have stronger muscles, you'll be healthier, you'll better, but from a weight loss perspective doesn't actually deliver the required results. Not
for enough people, guys. You're absolutely right. Like, I think eat less, move more is probably a good preventative approach, but when when people live with obesity and have certainly developed a health complication from it, it's beyond that. It needs treatment. There's a number of people, probably less than 10% of people with obesity can achieve significant weight loss, enough to benefit their health, and sustain that in the long term without any medical intervention. So without either getting an intensive weight management program where you offered medication and surgery. So it's not effective for the majority of people who but you'll hear stories of people who have managed that through diet and lifestyle changes.
There will be one, as with any element of the population, there will be 1, 2 or 3 people who can do it and who have done it, who might lose.
It's very unfair on patients who have tried that multiple times, and
Absolutely.
People can, like patients who come for surgery, have lost weight many, they've lost stones and stones over and over again. But it's well understood now. We know that when you eat less and significantly reduce your calorie intake, you get a rapid change in gut hormones that trigger that part of your brain that you have no control over, the hypothalamus, to make you more hungry, to decrease your metabolic rate, to adjust to that. Your body is designed to prevent you losing weight, to maintain your weight. So everything is going against you to maintain weight loss. So it's important that people acknowledge that it isn't their fault if they haven't managed to keep weight off that they've previously lost, and that there are medical treatments available. And you're right, there has been a long overdue shift in our understanding of obesity, and calling it a disease, which it absolutely is really important in terms of getting people, I suppose, reducing the stigma first and foremost that is so prevalent around obesity, and secondly then to allow good treatment programs to be put in place. There isn't obesity, you could say it's the most common chronic disease in Ireland, and until last week I suppose the only one that didn't have a funded treatment program is, so asthma has a treatment program, COPD does, hypertension, and yet obesity was just for a long time left for people to deal with themselves, even when it was significantly impacting their health. So I'm really delighted that it is getting the, I suppose, funding that it deserves, so that people deserve, when they live with this disease and have struggled with it for a long time, that they now have potential opportunity to access good, effective, safe treatments.
Chat to me about the importance of the psychology assessment. And it is a really, again, it comes back to, it's not just move more, eat less. And this is for all of us, by the way, the psychology of eating. Why we, in terms of for surgery, you are assessed before you go in. Tell me about why and why it's so important.
Yeah, I'd argue it's probably the most important part of the assessment. Like assessment for bariatric surgery requires multidisciplinary team assessment, and usually that consists of assessment by dietitian, nobody comes to bariatric surgery without having tried non-surgical options that are less risky. And bariatric surgery is very safe, but nonetheless, if you had an option that didn't involve being, having a knife put to your skin, you would choose it, so everybody has tried that before. And then for bariatric surgery, can be hugely destabilizing to change someone's relationship with food indefinitely. So psychology assessment is really important to make sure that a patient, I suppose, is suitable for surgery, that they have the coping skills required to have their relationship with food change. For many people, it has been food is a comfort. It is for all of us. It's implicated in every social interaction that we have, and it's a huge part of relationships with partners, with family, with friends. It's often quite central. It's central to every big event that we have. So all of a sudden you change someone's relationship with food. If they aren't prepared, that is really detrimental. And that's why it's so important to go into surgery well prepared and assessed by a psychologist. Firstly, make sure, you have the coping skills required. You have other coping skills than food to deal with traumas that inevitably crop up throughout life. And secondly, that someone is prepared. They know what to expect, and they know that when life throws them different challenges, how they can meet those without resorting to, I suppose, comfort eating or food to cope with that. And secondly, there's no, there are very few contraindications to surgery, and certainly any pre-existing psychological illness is not a contraindication to surgery, but it's important that it's well managed. So the psychologist also addresses people who have disordered eating, that's identified and treated also by the dietitian, and they work in tandem. We do work as a team. I'd argue as well, actually, that the surgeon is probably the least important member of the team. We have our bit on the day of surgery, but in terms of patient selection and preparation beforehand and then afterwards, it's the psychologist and dietitian do a lot of the work in getting patients well prepared for it.
Chat to me about the travelling for surgery component to it. I know we had someone on, a couple of months ago. Really interesting guest. She went abroad. Since then, it's been a lot of stuff in the news around it. People having complications. You're seeing this on the front line, so I'm fascinated with your view on it, but what you're seeing on the front line in terms of people who are going away for surgery and coming back. I'm intrigued by your own thoughts on it.
Yeah, so I completely understand why people go. They feel when they've looked into it, and it's a very safe and effective treatment first and foremost, and people are smart enough they do their homework and they acknowledge and understand that it is not a quick fix. It's probably the hardest treatment to pursue and to undergo, because for the most part it's irreversible, and it has a risk that dieting and that medications don't have. And I understand that people feel they can't wait 4 or 5 years to get an appointment in our clinic, or if they were to seek it privately, it's too expensive.
What's the cost privately here?
So health insurance does cover it, but if someone doesn't have health insurance, it covers it under the conditions I mentioned earlier. So when BMI is a certain number and have health problems and have been through a defined period of non-operative weight management beforehand and have had all the assessments that I mentioned as well. So there's a number of criteria applied, but then it does cover it. And then if someone was to self-pay in Ireland, it's between about 16 and 18,000. So it's really, really expensive. Okay. And it's cheaper abroad, so it's as people can get deals. I've seen them advertised sleeve gastrectomy for 3,000 in different clinics around Europe. So my worry about that is, I suppose I have a biased view of it because I see back the complications, and I probably don't see back as many people who have gotten through unscathed and who have had the usual result we would see, which is great weight loss, improvement in health, in mobility and quality of life. And who have had no complications. But there is, people would argue they are assessed well beforehand, but it's done in one day when people go over, realistically.
Pre-surgery.
Yeah,
really?
my experience with patients when I've asked them about it is that they arrange it all. They talk to a representative, it's all arranged by phone or virtually, and they go over the day before their surgery. They have, a range of blood tests, an ECG, a heart tracing, potentially an endoscopy to look at their stomach, but their surgery is scheduled for the next day, and I've yet to meet anybody who didn't proceed to surgery based on the preoperative test. So my experience is it's a given that if you go over and you're willing to pay, you're going to get an operation that you've chosen, rather than really be guided towards by a team who have your absolute best interests at heart in terms of your health, and have taken all of your history into account.
And presumably you're not getting the key component, which I totally agree with you, which is the psychology. Yeah.
No, I've never met anybody who's had psychological assessment or preparation for surgery, and that's my biggest concern about it. Is so a lot of people are so resilient, and they understand their eating behaviours and patterns, and if they feel less hungry and more full, they will lose weight, afterwards. But it's a colleague of mine always tells people bariatric surgery won't make you thin and happy. And I didn't like that statement when I
good
first
though.
heard it,
Yeah.
but it's absolutely true.
Absolutely.
So you don't undertake bariatric surgery, A, to be thin, or B, to be happy. It doesn't achieve either of those things. It does achieve weight loss and it improves quality of life, but they don't always equate to thinness and happiness. So I'd like people to know that I suppose, it does not do that, and it is life-changing, usually for the better, but there's a huge, psychological overlay to changing someone's relationship with food that dramatically, that often people need professional help and support with, that they can't do alone and shouldn't have to. They're offered, most patients who undergo surgery abroad are offered lifelong follow-up. It's marketed and advertised really well, but when people go to seek that, all of a sudden it's a phone call or it's not available, and that really worries me about it. And we get the fallout from that in our service.
Well, what are you seeing? Yeah.
So we're seeing, I suppose, the major impact is on the number of people arriving back with serious complications. So this surgery is really safe. It's as safe as somebody having their gallbladder taken out for the most part, and most people wouldn't think that's a dangerous operation because it isn't. So bariatric surgery is safe. But my impression of some of the complications I've seen back, I don't know the denominator, so I don't know, is the rate of complications more than the 1% of major complications we would get, which is completely acceptable. That's the accepted rate of complications. And if it's more than that, you need to look, and you always look to see, can you avoid things? We do
So
lots
1 in
of
100.
Absolutely. That's the given kind of international accepted rate of major complications for bariatric surgery. So because I don't know the denominator, I know I'm unable to say if it's 5% or 10%. But with the cost, my impression from how inexpensive it is that corners are being cut somewhere. I know when we look at the cost of how do you deliver bariatric surgery as lean as possible in terms of the cost of the equipment, the theatre time, the staff to look after people well, it's expensive surgery. The kit, we use the absolute best of equipment available to do these procedures, and that costs a good portion of the money.
It takes time, not just for the waiting list, but if you're in, from the time you walk in the door to the time you walk out the door, it's probably 2 years.
From
over here in Ireland.
Absolutely, from once we do a 9-month assessment, monthly visits with the MDT, the multidisciplinary team, and then the surgical episode itself is actually quite short. Like when someone comes into hospital, they are fit for the most part to go home 2 days later when there's been no problem. But again, I worry about people travelling. There's already a risk. It's rare, but one of the biggest risks with bariatric surgery is of clotting, is of a DVT, a deep venous thrombosis, which is a clot in a vein in the leg, and the danger with that is it could travel to the lung. And if that happens, that's a PE or a pulmonary embolus. That's actually the commonest reason people would die after bariatric surgery. So it's less than 1 in 1,000 cases that would happen in. But you're adding a flight in on top of that, and it just increases the risk, I think, unnecessarily. But I've had, when I get people back, sometimes they actually don't know what operation they've had, and we're trying to go through notes in usually Turkish, I suppose, would be the commonest place people would travel to at the moment. Trying to decipher what operation has been done by using scans. So it's quite challenging then to treat problems when you really don't understand what was done in the first instance. But yeah, it's troublesome, and I like I said, I understand why people do it, and I would never discourage someone from getting the best treatment for their health, but I would I suppose advise people that they really need to have a plan in place for if they develop a problem, what are they going to do. At the moment, it's taking days for people to get transferred to us because of the pressure on beds. So often they're in perfectly well looked after in centres around Ireland, but not in a bariatric centre, and where they can't get specialist input should that be needed. A lot of the time we're just getting people back who are experiencing what I would consider quite normal symptoms after bariatric surgery, but they didn't know to expect them. So for a lot of people, they experience nausea, vomiting, and actually it's often fixed by the dietitian being involved and actually teaching somebody how to eat after bariatric surgery, and that wasn't done. People are told it, but they really paid lip service to it, and often people are so desperate is the wrong word to use, but intent on getting surgery that they don't maybe pay in one visit or one phone call, they really don't get the best, I suppose, input or preparation for surgery, so are left picking up the pieces afterwards. It's easier to prepare for it than it is to do the latter, do that to address problems once they've occurred afterwards, and all that's avoidable, by having for many patients. There's some people who, even when they're really well prepared, they know what to expect, they still struggle to adjust to life after bariatric surgery, and they get through that with the help of a multidisciplinary team. But the problem we face at the moment is we're getting, onslaughts of letters from people's GPs where the clinics that they've gone to said, go back to your GP and get lifelong follow-up. And again, the GP hasn't known the patient is gone, hasn't the resources to do that. So they're sending us letters and we simply don't have the resources. That displaces a patient on our waiting list. So, it's difficult to manage that. So we can't provide that routine care that people need when they come back from abroad, like, blood tests, which are quite frequent, 4 times in the first year after surgery to check that someone isn't developing vitamin deficiencies. I've had people back who are on no vitamins, and it is important to, and it's international guidance, to be on a certain number of supplements after bariatric surgery, because people aren't eating enough of their micronutrients in particular to be able to stay well nourished. So they do need a supplement regime, and it's best practice to prescribe that and to guide them on it. Patients have no idea what they should be on and often aren't on any. So it could take a year or two to develop symptoms from a nutritional deficiency. So often we see people later who are at that point, they've iron deficiency anemias and are symptomatic from that. And all that, I think, is so avoidable, if people go into it well prepared and know what to expect and how to manage it.
This stage, I normally ask people, people want to get in touch with you, where can they find you? With yourself, I'm going to say, if people want to find out more about maybe the Loughlin program or their own, if they're listening in, where is it? Is it a HSC website you go through, or a GP that you go through? I know there is a large waiting list, but
yeah, it's a good. We need to get that prepared. We have a very rudimentary website for Loughlin's program, and you're absolutely right. I need to
go
to
to
change
Instagram
that.
yourself and Donal. And Donal was in it off mic. I said the same. It was like, seriously, it's like for the expertise that come when I chat to yourself or to Donal is just but it needs to be, absolutely.
We have for the service in St Vincent's Private Hospital, which I work in as well, so we have prepared a video. It's an hour-long video, freely available on the Vincent's Private website, that outlines, I suppose, the important. It outlines all obesity treatments first and foremost, and all of our team speak to their area of expertise. So our dietitian, our psychologist, actually also gives a 20-minute talk on important psychological aspects to preparing for surgery and living with it afterwards.
What we might do is, when the episode goes out, if you email that over to me, I'll post it through my own Instagram stories, the link to it and stuff. We can get people.
That's probably the best resource, but we do need to do better in terms of putting more resources that are easily and freely available to people. And I've absolutely no issue with doing that. It's something. It's on the to-do list.
You've a lot to do, in all fairness, and thank you so much for coming in today to give us what has been a fascinating half an hour. If nothing else, you've cleared up the different types of surgery, the pros, the cons, and it's a fascinating insight into your world, so we really appreciate it. Folks, that is it for another episode of Real Health with me, Carl Henry, in association with Leia Healthcare. You know where we are, at Carl Henry PT on Instagram, realhealth@independent.ie, and hopefully you've liked what you've listened to, so don't forget to rate and review. We'll see you next week. Slán go fóill.
Leia Healthcare, looking after you always. Proud sponsors of Real Health with Carl Henry.